Hello, let us start with intravenous anesthetic agent. So, anesthesia started with inhalational anesthetic agent, that is with ether, by W.T.G. Morton on 16th October 1846-7, right? But just with ether, the induction, the process of making patient unconscious was very traumatic for the patient. And this trauma of the patient was eliminated with the first IV anesthetic agent, which came in 1934, and the name was thiopentone. This thiopentone was introduced by Dr. John Lundy. Dr. John Lundy, who gave the concept of balanced anesthesia. So thiopentone mostly in that era was used for induction. It gave a very fast induction, right? Very fast induction and very quick recovery if required, right? And its context sensitivity time, elimination time, everything, the pharmacokinetic was very predictable. So it became a very popular agent for induction. Now, can we use it for maintenance? Yes, thiopentone could be used for maintenance, but it was not very suitable agent to be used for maintenance. Why? Because of its accumulation in the tissues and the fat of the body and taking a very long time to get eliminated. Its context sensitivity half-life was very delayed. It has a very long context sensitivity half-life. So it was not a suitable agent for maintenance. With introduction of newer IV anesthetic agent after 70s, for 50 years, for nearly 50 years, thiopentone dominated. But after 1970, still not came in clinical use, but after 1970, the newer agents were getting introduced. So came our ketamine, came our propofol, came our remifentanil, right? With introduction of these agents, the role of IV anesthetic agent more increased, not only for induction but also for maintenance of anesthesia. And with introduction of variable delivery infusion pump, right? And with introduction of monitor for depth of anesthesia, a closed loop anesthesia, IV anesthesia delivery system was developed. And today, in modern era of anesthesia, the role of IV anesthetic agent is immense. Now, what is an ideal IV anesthetic agent? First was thiopentone, which was not so ideal. Now we have so many other agents. What is ideal IV anesthetic agent? Hemmings published a report in which he gave the criteria what should an ideal IV anesthetic agent should look like, and that is what I have tabulated here. Now, ideal IV anesthetic agent should produce hypnosis, it should produce amnesia, it should be fast, it should not have any effect on cardiovascular system and respiratory system, it should not be toxic, it should not cause complications like pain on injection. Well, does any IV anesthetic agent fulfill these criteria? All these criteria? No. This looks perfect, but we don't have any IV anesthetic agent which fulfills all these criteria, right? Propofol, one of the most commonest used IV anesthetic agent. This is called gold standard for IV anesthetic agent. Does it fulfill all these criteria? Not at all. Yes, it has fast onset, it is anti-emetic, it gives a very rapid recovery also. It has a huge volume of distribution, so context sensitivity half time is also less, so it is eliminated from body fast, right? But is it without any side effects, without any problem? It is cardiovascular unstable, it causes pain on IV injection. On prolonged infusion, it can cause propofol infusion syndrome, right? It is fat soluble, not water soluble. Lot of things in propofol which takes it away from being an ideal IV anesthetic agent. So no agent is an ideal IV anesthetic agent, right? So we will discuss all the agents. We will discuss what are their advantages, what are their disadvantages, what is their pharmacokinetic, what are their pharmacodynamics, and then if we know all these things, it would be very easy for us to choose for our patient which IV anesthetic agent in this scenario would be perfect. Okay, so let us start our discussion with some important common pharmacokinetic of all IV anesthetic agent. So how do we give an IV anesthetic agent? Definitely, we give it intravenously. So whenever we give the drug intravenously, what happens? It gets distributed in the organ, first rapidly into vessel-rich organ. So it goes more into vessel-rich organ, that is the organ which gets more perfusion, like central nervous system, right? The patient becomes unconscious, okay? And now when this serum concentration decreases, from CNS, it gets dissociated and come back in the blood. And from blood, it gets redistributed to other organs, right? Like muscle, fat, etc. So this, what is happening? This redistribution. And because of this redistribution, patient regains the consciousness. Right? So to understand this pharmacokinetic is very essential for IV anesthetic agent, to understand how we need to deliver it for maintenance of anesthesia. For induction, we give a single IV dose. It goes to the vessel-rich organ, produces unconsciousness. And once the serum concentration decreases, it will get redistributed to other organs like muscle, fat, and patient will regain the consciousness. So to maintain the unconsciousness, to maintain this unconsciousness of the patient, we have to maintain the serum concentration. We have to maintain serum concentration, right? So to maintain the serum concentration, we have to give infusion. We have to give a continuous infusion. So when we give continuous infusion, what happens? It goes to the vessel-rich organ, right? From blood, from IV, it goes to the vessel-rich organ, CNS, and it maintains the CNS concentration. Patient remains unconscious, right? It also goes to other organs, right? We have to maintain this IV concentration. It also goes to the other organs, right? And from blood, it also starts getting metabolized, eliminated also, okay? We have to maintain a balance between the elimination, distribution to the other organs. Then only the required concentration will go to the CNS and the unconsciousness will be maintained. See, when we are giving IV anesthetic for a considerable duration, then the other compartments gets filled up, right? So from blood, elimination to the other organs is minimized. So serum concentration is now more maintained, can be more maintained at a lower maintenance dose, lower infusion dose, right? So over the course of maintenance with these IV anesthetic agent, we need to decrease their dose. Otherwise, what will happen? A delayed recovery, more complications of these agents will appear. So we have to understand this pharmacokinetic of IV anesthetic. What did I tell you? I told you that when we give the drug intravenously, it is distributed. Initial distribution happens, right? More to the vessel-rich organs. Then it is redistributed, right? How it is redistributed? From the blood to the other organs, and from CNS and all the vessel-rich organs, it will come again back in the blood and then again will get redistributed. So it is redistributed. And finally, elimination. This is the elimination. Okay. So this is the three-phase distribution of an IV anesthetic agent. And to make you understand it in a more simple way, this is an hydraulic representation of three compartment hydraulic representation of how the IV anesthetic agent is distributed in the body. So this central compartment, this is the blood. This central compartment is the blood which we are filling, okay? And from blood, this is the how it is getting eliminated. Okay. From blood, how it is getting distributed? One, the fast distribution to these organs, which are vessel rich organ, they are less in mass. And second, the slow distribution to other organ, which are more in mass, right? But the distribution is slow because they are less perfused. So to maintain the serum concentration, we have to balance between this fast distribution, slow distribution and elimination. Then only the serum concentration will be maintained, and then only the CNS level will be maintained. Okay. So over the course of time, when this other compartment gets saturated with IV anesthetic agent, the distribution, the movement to this compartment is less. So at a lower dose, more and more serum concentration can be maintained, right? So over the time of infusion of IV anesthetic agent, we have to decrease the dose to prevent the delayed recovery and other complications. Okay. Now let's say discuss how our IV anesthetic agent is eliminated. There are two, let's say, nomenclature regarding elimination which we are aware of. One is elimination half-life and other is context sensitivity half-life. Now let us talk about first elimination half-life. Now this is a very simple term which cannot hold with this tri-exponential distribution of IV anesthetic agent. What is elimination half-life? This means that when we give a drug, right, how much time it takes its concentration to get halved in blood. So when we give drug, it is in blood, one compartment, only one compartment. Okay. And now we have stopped giving it. How much time it takes to become 50% is elimination half-life of that drug. Now this cannot hold true. Calculating this cannot hold true for IV anesthetic agent because it does not follow it is not distributed in only one compartment, that is blood. So we have to understand something called context sensitivity half-time. What is context sensitivity half-time? Context sensitivity half-time is time required for decreasing the 50% of the serum concentration of the drug, considering its distribution in all the compartments of the body, right? So it is also time required to decrease serum concentration by 50%, considering all the factors like distribution, redistribution and elimination over the time. Distribution and redistribution, right? So this holds more true for IV anesthetic agent. And the drugs which have a low context sensitivity half-life, if we give them by a continuous infusion for even a longer time, they go out of the body quicker, right? So drugs with low context sensitivity half-life would be preferred for maintenance of general anesthesia, because even if we give them for a longer duration, their elimination from blood is not delayed. If we see this graph, I have shown different IV anesthetic agent, their context sensitivity half-life and infusion duration. If you see propofol, if I am giving it for a long infusion, 1 hour, 2 hour, 3 hour, 4 hour, 5 hour, 6 hour, 7, 8, 9, its context sensitivity half-life, that is time in which the serum concentration is getting 50% reduced, is not very much increasing, right? It is not, this is the propofol, the maroon one, right? It is not very much, let's say, decreasing. Okay. So basically, propofol has a low context sensitivity half-life. If you see thiopentone has a high context sensitivity half-life. They need more time to get cleared from the blood when we are giving them in the form of infusion. You can see as the infusion time period is increasing, thiopentone, the context sensitivity half-life time period is also increasing. So more the infusion time, more it will take the time to get eliminated. So definitely propofol would be preferred if we want to have a fast elimination of the drug, and that is a preferred thing in maintenance of anesthesia. There is one opioid IV anesthetic agent, remifentanil, which I will talk in opioid. It is independent of its infusion rate. You stop it and it is eliminated from the body. So its context sensitivity half-life is independent of its infusion rate. So that is a perfect drug for maintenance of anesthesia. Got my point, everyone? So let us talk about now different IV anesthetic agents. I told you thiopentone has a long context sensitivity half-life, so it is not preferred for maintenance of anesthesia. And now thiopentone kind of getting slowly eliminated from clinical practice, and it is more or less getting replaced by the today's gold standard propofol. Though propofol does not fulfill all the criteria of an ideal IV anesthetic agent, but it has some very good points which makes it a very suitable drug in clinical practice. So let us start our first drug, propofol. But before, let's say, coming on the drug, one quick classification of how I will discuss these drugs we should do. Okay, so I would classify your IV anesthetic agent to two groups: non-opioid, which would be a diverse group, non-opioid, diverse group, in which drug belonging to any other group except opioid and is used for IV induction will be discussed. And the second group would be opioids, right? Drugs which comes under the group opioids. In non-opioids, we need to know about propofol, right? Propofol, which is diisopropyl phenol, and this would be the first drug I will discuss with you. Then etomidate. Etomidate is imidazolone derivative. Imidazolone derivative. Third, ketamine. Ketamine is phencyclidine derivative. Phencyclidine derivative. Then your benzodiazepine. Benzodiazepine. In benzodiazepine, three important drugs of interest: midazolam, diazepam, and lorazepam. Lorazepam. Okay, and then barbiturates. Barbiturates. In barbiturates, three drugs can be used as IV induction agent: thiopentone, the first IV anesthetic agent historically, thiamine, and methohexitone. Methohexitone, right? So this is non-opioid group. As you can see, it's a diverse group. All the drugs belonging to this group are of some different chemical. They are chemically different from each other. So this is a diverse group. Opioids. Opioids. What are the drugs in opioid group which can be used for anesthesia, right? Your morphine, fentanyl, pethidine, your alfentanil, sufentanil, remifentanil. All this can be used for induction and maintenance of anesthesia at a very high dose compared to dose in which it is used for analgesia. Now, before going on propofol, just very quickly I want to tell you one thing, that most of the non-opioid IV anesthetic, barring few of them, they are cardiovascular unstable, right? Cardiovascular unstable, a major demerit of non-opioid. And opioid, most of them are cardiovascular stable even on high dose, So mostly opioid during GA is used for analgesia, but can also be used for anesthesia in high dose because they are cardiovascular stable. So for certain clinical conditions, their use would be preferred over non-opioid. But otherwise, our routine IV anesthetic agent which we use is non-opioid. And the first non-opioid I will discuss with you is propofol, right? So propofol, let us discuss propofol. So first point of propofol, what is the chemical nature of propofol? Propofol, as I already told in the classification, is diisopropyl phenol. It is diisopropyl phenol. Okay, 2,6-diisopropyl phenol. Okay, now this is not soluble, right? It is highly lipophilic, and its relative insolubility in the aqueous solution was a major problem. So it is highly lipophilic. So its lipophilicity and insolubility is a big problem. So what was done? The first time it was prepared in camphor EL preparation. That camphor, so first time it was prepared in camphor EL preparation. This was causing a lot of this can cause anaphylaxis. Since it was insoluble, we required a vehicle which would make it soluble intravenously. So first time it was introduced with camphor EL, but it used to cause anaphylaxis, can cause anaphylaxis. So it was, at that time it was removed. Now after, let's say, a few years, a new preparation was introduced. A new lipid emulsion preparation of propofol was introduced, which was white in appearance. It was milky white, rather, I would say. Milky white in appearance, right? And it was soluble intravenously. It was a soluble lipid emulsion. Soluble lipid emulsion of propofol. So what was that commercial preparation of propofol containing? So commercial preparation of propofol which was introduced had 1% this 2,6-dipropyl phenol, 1% propofol, right? 1.2% egg phospholipid, 2.25% glycerol, 10% soybean oil. Now these produce this lipid emulsion. This was used for emulsification. Later on, EDTA was added. This EDTA was added to prevent the microbial growth in the propofol. Okay, so today the commercial preparation has all these things. It is white in appearance. It's now a lipid emulsion. Okay, this is about the chemical nature, appearance, and additives added to propofol to make it soluble intravenously. Now let us talk about pharmacokinetic of the propofol. Pharmacokinetic. Okay, now propofol, when you give IV, as I told you, like any IV anesthetic agent, it will first get distributed to highly perfused organ, right? That is called rapid initial distribution phase. We call it rapid distribution phase. Then from as the serum concentration will decrease, right? From the target organ, it will come back in the serum, and it will start getting redistributed. Whatever is remaining in the blood and whatever comes from the highly perfused organ starts getting redistributed to other organs. That would call slow distribution phase. And finally, from the blood, it will get eliminated. That would cause elimination phase. So I am writing that propofol initial distribution 1 to 8 minutes. It takes 1 to 8 minutes. Slow distribution or redistribution, rather we should say. So slow distribution half-life 30 to 70 minutes. And elimination half-life 2 to 24 hours, depending upon the infusion rate. Now, studies have shown that if we give propofol infusion for duration 8 hours also, right, the context sensitivity half-life is hardly 40 minutes or less. So context sensitivity half-life is 40 minutes or less. So see, even for 8 hours infusion, it will become half in the blood in just 40 minutes and maybe get eliminated in, let's say, less than 2 hours. So it has a very fast elimination half-life. So that makes it a very suitable agent for infusion, for maintenance of general anesthesia. Now, how is propofol metabolized? How is the metabolism of the propofol happening? Now, metabolism of propofol and most of the IV anesthetic agent is from liver, right? It gets metabolized in liver, right? To the metabolites which are inactive, water soluble, and mainly they are eliminated from kidney. So metabolism in liver to metabolites which are inactive and water soluble, primarily excreted from kidney, Now, clearance rate of propofol is very high. 20 to 30 ml per kg per minute. 20 to 30 ml body weight per kg body weight per minute. So clearance rate is very high. And this high clearance rate does not match the hepatic blood flow. The hepatic blood flow is 15 ml per kg per minute. Okay. But the clearance rate of propofol is 20 to 30 ml per kg per minute. And metabolism is from liver. So liver is not solely responsible for its metabolism. Since the clearance rate is higher than the hepatic blood flow. So there are some extra hepatic sites from which the propofol can get metabolized. So what are the extra hepatic sites? Extra hepatic sites of metabolism. The extra hepatic sites of metabolism is 2 sites mostly, lungs and kidney. So that is why it has been implicated that propofol can also be used in patient with liver dysfunction comfortably without getting the context sensitivity times increased very high, because of the other organs also involved in its metabolism, right? So even if liver is not working properly, the metabolism can also take place from extrahepatic sites. So elimination is not much affected in liver dysfunction patient also. So propofol can safely be used in patient with liver dysfunction. Okay. Now let us discuss the pharmacodynamics of propofol. Pharmacodynamics, that is the site of action of the drug and action of the drug on other organ systems also. The desired and the undesired effect of the drug in our body is what is pharmacodynamic. So pharmacodynamic of propofol, what is the mode of action or site of action of propofol? So site of action. Site of action mostly in CNS on GABA receptor. On GABA receptor, right? What does it do? It enhances the GABA inhibitory pathway. Enhances GABA inhibitory pathway. Okay. So this is GABA inhibitory pathway is enhanced and the unconsciousness can be induced and maintained. Okay. Now propofol not only acts on GABA receptor, it can also act on some more receptor. Its effect on some more receptor has been shown, like it can act on alpha adrenergic receptor. It can act on N-methyl D-aspartate receptor. And it can also act on cholinergic receptor. It has central cholinergic action. So cholinergic receptor. It can also act on cholinergic receptor. Okay. So mostly it acts on GABA receptor. It enhances the GABA inhibitory pathway, right? Which is GABA, it enhances the GABA inhibitory pathway. So inhibition of the neurotransmission takes place in the brain and the patient goes into unconscious mode. It can also act on alpha adrenergic receptor and methyl D aspartate receptor and as an N-methyl D-aspartate antagonist, and it can also act on cholinergic receptors. So it can act on multiple receptors, but the main work is through this GABA inhibitory pathway. Okay. Now, so this is the mode of action of propofol. Now, what is the effect of propofol on, other effect of propofol on central nervous system? Okay. What is the effect of propofol on EEG? Electroencephalogram. Now, when, like any IV anesthetic agent, propofol would also produce unconsciousness. So there would be a change in the pattern of EEG waveform from high frequency to low frequency. So from beta to alpha to predominant theta waveform would get established in under propofol anesthesia. It leads to the burst, it leads to gradual inactivity of the brain, and it leads to the burst suppression. And because of this burst suppression seen in EEG, it is the, let's say, cerebroprotective effect of propofol. This constitutes the cerebroprotective effect of the propofol. So in EEG, the change in pattern, change in EEG pattern from high frequency to low frequency waveform. Low frequency waveform, that is from beta to alpha to delta to theta. There is a burst suppression on the bolus dose, burst suppression of electrical activity, and this constitutes the neuroprotective effect. This burst suppression is important for neuroprotective effect, neuroprotective role. Okay, so this is the main neuroprotective role of propofol. Now, because it decreases the EEG activity by making the activity of the brain, it decreases the EEG activity. Why? Because it decreases the activity of the brain. This causes decrease in cerebral metabolic oxygen requirement. Cerebral metabolic oxygen requirement. Because of this decrease in cerebral metabolic oxygen requirement, there is a decrease in cerebral blood flow. We talked about CNS coupling. We talked about CNS coupling, right? In inhalational, I told you that cerebral blood flow is directly proportional to cerebral metabolic oxygen requirement. If cerebral metabolic oxygen requirement reduces, as happening with propofol, the cerebral blood flow, if cerebral metabolic oxygen requirement increases, cerebral blood flow would increase, and if cerebral metabolic oxygen requirement decreases, the cerebral blood flow would decrease. This is called CNS coupling. Okay, so propofol causes CNS coupling, and because of decreased cerebral blood flow, intracranial pressure would decrease. Intracranial pressure decreases. Okay, so again this constitute the neuroprotective role of propofol by decreasing the CMRO2, right? 30-40% decrease in oxygen requirement of brain is done by propofol. Now, what is the other neuroprotective effect apart from the burst suppression? The first one, decreased CMRO2, decreased intracranial pressure. Second and third one, the other one is antioxidant effect. Antioxidant effect on brain. Antioxidant effect. It is free radical scavenger. Radical scavenger, and it prevents the, it has a role in preventing the neurodegenerative process after stroke and other CNS insult. So it prevents degenerative process such as stroke, such as in stroke and trauma. Then it has anticonvulsant effect. Other good thing on brain, anticonvulsant used in anticonvulsant, it is used in status epilepticus. Status epilepticus. Okay. And one bad effect of propofol on central nervous system: substance abuse potential, addiction potential. So it has some addiction potential. You know, propofol produces euphoria. It produces euphoria and it gives a sense of well-being. Sense of well-being, right? And this contribute in two things. One, addiction potential, and other, gives a very pleasant recovery after anesthesia. So propofol, one good effect of propofol, it gives a pleasant recovery because it's a euphoric drug, gives a sense of well-being, right? Then another effect on central nervous system, it inhibits the CTJ center, responsible, the chemoreceptor trigger zone, right, responsible for producing nausea and vomiting. It inhibits it. So it prevents nausea and vomiting. So another wonderful effect of propofol. Propofol prevents nausea and vomiting. It gives a pleasant recovery, it prevents nausea and vomiting, and all other good effect, neuroprotective effect of propofol on central nervous system makes it a very suitable drug for neurosurgery. So propofol is a very suitable drug used for neurosurgery, right? IV anesthetic agent has a little edge over inhalational for central nervous system surgery. Why? Because inhalational, even the best one, has a little potential of increasing ICP because they are uncouplers. They do not follow the rule of coupling because they dilate the blood vessels of brain. This is not seen with IV anesthetic agent. Propofol has a very huge role in neurosurgical procedures for induction and maintenance of general anesthesia. So this is good for neurosurgery. Agent is good for neurosurgical procedures. Okay. Now let us discuss the effect on cardiovascular system. I told you, most of the non-opioid IV anesthetic agent, cardiovascular unstable. Propofol is also cardiovascular unstable. One major issue of propofol, cardiovascular instability. So propofol, hemodynamic effect is dose dependent. Effect is dose dependent. Remember, less dose, less hemodynamic imbalance would be seen with propofol. So it's dose dependent. What does propofol do? Decreases systolic and diastolic blood pressure. Typically without increasing heart rate. So this is the main effect on hemodynamics, without increasing heart rate. So because of this, decreases systolic and diastolic. Why this happens? Why propofol decreases systolic and diastolic blood pressure? And why is heart rate not increasing? The systolic and diastolic blood pressure is decreasing because of three effects. Decreases cardiac output, decreases stroke volume, and decreases systemic vascular resistance, causes vasodilatation. Systemic vascular resistance, right? And it inhibits the reflex sympathetic activity. So inhibits reflex sympathetic response. So when it inhibits reflex sympathetic response, heart rate does not change. Okay, got it? Apart from this, it decreases cardiac contractility, right, by decreasing the myocardial calcium level. So it decreases cardiac contractility by causing myocardial depression, by creating an imbalance in calcium, right? So because of all this, and it also has an effect on conduction system of the heart. It decreases the heart conduction system. Conduction system. So what I would say in summarizing, that propofol is cardiovascular unstable, and this instability is dose dependent. If you manage the dose properly, this may not appear. It would happen more with high dose, more with a bolus dose, right? So if instead of bolus dose, we give a graded dose of propofol, right? This cardiovascular instability would become less. What if I give a bolus fast dose, that is bolus dose, what will happen? It will decrease the blood pressure. It can cause myocardial depression, right? It can decrease the cardiac output. It can cause hemodynamic imbalance. It can cause even sometimes arrhythmia because it affects the cardiac conduction system. So it is better not to give propofol in a fixed predetermined bolus dose. Rather, slow graded dose would be preferred. Dose would be preferred, right? Now I would tell you, when I will tell you the dosing, how do we do the dosing? Okay, so remember this: propofol is one of the cardiovascular unstable agent, and it is not preferred or used in patient in shock. So in shock patient, we not use propofol. Why? It is cardiovascular unstable. Okay, right? If I compare cardiovascular instability of propofol with inhalational, I would say propofol is more cardiovascular unstable. Okay. Now, next effect is on respiratory system. Okay. Respiratory system, again the effect is dose dependent. Fast bolus dose, immediate apnea at high dose. So again respiratory is dose dependent. Okay, dose dependent. Apnea at higher dose. Apnea at higher dose, that is induction dose produces apnea, right? Maintenance dose, if I give less dose, maintenance dose, it would, like any other anesthetic agent, decrease tidal volume and increase the respiratory rate. So little effect on the minute ventilation. And like any anesthetic agent, it will blunt the hypoxic and hypercapnic drive to hypoxic and hypercapnic respiratory drive, right? So blunts respiratory drive, blunts respiratory drive, right? Hypoxic and hypercapnic drive. And one very good effect of propofol, it's a very good bronchodilator, one of the best bronchodilator. It's a very good bronchodilator, right? Why? It produces a relaxation of the smooth muscle, right, by decreasing the calcium. So relaxation of bronchial smooth muscle. So today, for bronchial asthma patient, I am preferring the propofol because it's a wonderful bronchodilator, right? So this is the respiratory effect. Now let us see, how do we give propofol? What are the clinical? Now see, we discussed respiratory, we discussed cardiovascular, we discussed CNS, right? I didn't tell you about hepatic and renal. Remember that propofol is metabolized by liver and it has extrahepatic route of metabolism also. This is the only thing which we need to know about the effect of propofol, relationship of propofol and liver. Propofol has no bad effect on liver as such. Neither it has any bad effect on kidney. So patient with liver dysfunction and patient with kidney dysfunction, we can use propofol, right? So patients with liver and kidney dysfunction, propofol can be used. Okay. Now let us see, how do we use it? The most important use of propofol is for induction of general anesthesia. Induction of general anesthesia, right? Now what is the induction dose? The broad induction dose. Induction means to make the person unconscious. For unconsciousness, right? To make the person unconscious, the dose is 1 to 2.5 milligram per kg body weight, right? Now, this dose is variable according to the patient characteristic and comorbidity. So, this would vary according to patient's characteristic and comorbidity. Okay. If I am giving propofol to an elderly person, then the dose needs to be reduced. Needs to be reduced. Less is required. Why? Because of slow volume of distribution and slow clearance. Because of slow volume of distribution, volume of distribution and slow clearance, right? The dose has to be reduced. In pediatric, just opposite. Pediatric, the requirement would be high. Dose is increased. Why? High volume of distribution and high clearance. High volume of distribution and high clearance. Okay. Now, for obese patient, if I am giving propofol to obese patient, the dose is described in milligram per kg body weight. But we don't calculate the dose of propofol in obese according to total body weight. The dose is calculated according to lean body weight. So, obese dose is calculated, the induction dose, according to lean body weight, right? Not total body weight. In cardiac disease, right? The dose of propofol, if we will give fixed dose, there will be exaggerated hemodynamic imbalance. So, we have to give slow incremental dose. Cardiac disease, fixed dose will produce exaggerated hemodynamic response. So, incremental dose is given. We give incremental dose. So, this is how, according to the patient's characteristic and comorbidity, the dose of propofol, induction dose has to vary. Okay. Now, let us talk about the second use of propofol for maintenance of general anesthesia. For maintenance of general anesthesia, right? The maintenance dose of propofol is 100 to 200 microgram per kg per minute infusion. 100 to 200 microgram per kg per minute infusion. So, it is given through infusion 100 to 200 microgram per kg per minute, okay, for maintenance dose. And over the time, according to the monitoring, right, we need to reduce this maintenance dose because the peripheral compartment gets saturated with propofol, right? So, what will happen? More serum concentration can be maintained at a lesser dose. So, this is the range of the dose. Some books even write 100 to 300 microgram, right? You have to titrate it according to the hemodynamic response of the patient and according to the monitoring, BIS monitoring, that is depth of anesthesia monitoring, right? Gradually over the time, lesser dose will produce same depth. If you will continue giving the same dose throughout, then more hemodynamic imbalance and more the patient will go towards a coma, the increased depth. So, recovery would be delayed. So, you have to titrate it. Then the third use of propofol, we use it for sedation. We use it in ICUs for gastrointestinal procedures. We use it for sedation, right? So, sedation dose is 25 to 75 microgram per kg per minute infusion. Some books write it 50 to 100 microgram per kg per minute infusion. Actually, again, you'll have to titrate it according to the patient's response and according to the hemodynamics. So this is the range for sedation, and we use it for like so many different conditions. We use it for sedation in ICUs, propofol. We use it for sedation in gastrointestinal procedures. Propofol has one huge benefit to be used for GI endoscopy, gastroendoscopic procedures as a sedative. Why? Because in gastroendoscopic procedures, which are mostly done in sedation, since the delivery of inhalational, the route, they put the endoscope from the same route. The route of inhalational is also same through lungs. So since we share, it is very difficult to give inhalational through for GI procedures. So IV, TIVA is more preferred. Total intravenous anesthesia is more preferred, right? And propofol is highly preferred because it has low contact sensitivity half-life, so it will give a faster recovery. It has a fast action, fast recovery, it does not accumulate, is anti-emetic, right? It gives a pleasant recovery. So all this makes a beautiful procedure for gastroendoscopic procedure sedation, right? So it's a beautiful for GI procedures. Okay. Then the fourth use of propofol. Fourth use is for as an anti-emetic. Okay. This is the only IV anesthetic agent which is anti-emetic. All inhalational, they cause nausea, vomiting. Nitrous oxide, highly nauseous and vomiting. IV anesthetic also cause nausea, vomiting. Only propofol, anti-emetic. And the dose is very less, 10 milligram, 10 to 20 milligram IV. Or if I am giving from infusion, 10 microgram per kg per minute is enough for anti-emetic dose. Okay, so we use it for as an anti-emesis also, this propofol. Okay, so we use it for induction of anesthesia, we use it for maintenance of anesthesia, we use it for sedation in ICU, we use it as anti-emetic, and one unique effect is antipruritic effect. Antipruritic effect, right? It decreases the pruritus, and same dose, 10 to 20 milligram. 10 milligram to 20 milligram IV. Okay, so this is the pruritic dose, antipruritic dose of propofol. Now coming on the side effects of propofol, one of the main side effect, 60 to 70% patients shows the side effect, and that is pain on IV injection. So IV injection causes pain in 60 to 70% patients. Reason? What is the propofol? Propofol is diisopropyl phenol. This phenol, right? This causes veno irritation. Right? By interacting with endothelium of vein. So it causes irritation of the endothelium of vein. So what happens? Immediately patient has pain because of the irritation, and it can cause, let's say, immediate pain and little delayed pain also because of release of kininogen, inflammatory mediators like bradykinin, etc. mediators. So it causes an inflammatory reaction by interacting with endothelium, causes the kininogen pathway to get activated, and causes bradykinin release, and this causes pain. So it causes veno irritation, direct irritation also causes pain, and release of inflammatory mediator also causes pain. So how can we manage? How would we prevent this pain? So management, we can do number of things to prevent this pain. Number one, we can give prior to propofol injection lidocaine with tourniquet or without tourniquet. So prior to propofol, lidocaine with or without tourniquet, right, is given to decrease this veno irritation. Then pre-treatment with opioids. pre-treatment for nociceptive effect, treatment with opioids. Okay. Then use of those formulation which has low free propofol. See, propofol, we have different kind of formulation. One is LCT formulation, that is LCT, and one is LCT MCT formulation. LCT MCT formulation, that is middle chain triglyceride, low chain triglyceride. This LCT formulation, this keeps more free propofol, and propofol, the phenol, is responsible for this veno-irritation. So LCT preparation, like, they cause more pain, and LCT MCT mixture preparation causes less pain. So if we use the preparation, that is LCT MCT preparation, less pain. Then instead of the thin vein, if we use thicker vein, so what will happen? It will be more centrally. It will let's say it will touch the endothelium less. And if we give propofol fast and prevent any, let's say, very fast movement of the propofol, again they say the pain is less. So antecubital vein, less pain. So all these measures would decrease the pain caused by propofol. Okay. Then the other side effect, a very notorious side effect with a mortality of 50%, is propofol infusion syndrome, or PRIS. Right? This is life-threatening with a very high mortality of 50%. This is life-threatening, right? With high mortality, right? And it depends upon dose and duration. It depends on dose and duration, right? If we give high dose and for more duration, the risk is more. So more duration means more than 48 hours if I am giving propofol, and high dose means if I am giving 5 milligram per kg per hour, right? More than 5 milligram per kg per hour. More common in children, it is more commonly seen in children. Okay. What happens? Clinical features. What is the clinical features? The clinical feature is unexplained acidosis, hyperkalemia, renal failure, right? Liver dysfunction, ECG changes, cardiac failure, progression to cardiac failure. So this is life-threatening. Now what is the reason why this happens? Exact etiology is not clear, but the most probable cause is mitochondrial. Toxicity. Got it? What it does, it causes uncoupling of intracellular respiratory chain. So it causes mitochondrial toxicity, which results in uncoupling of intracellular respiratory chain. Okay. And some says that it affects the lipid metabolism. So inhibits lipid metabolism also, affects the lipid metabolism also. That's why hyperlipidemia can also be seen with it. Hyperlipidemia. This is the reason why hyperlipidemia can also be seen. So unexplained acidosis, hyperkalemia, renal failure, liver dysfunction, hyperlipidemia, ECG changes, and cardiac failure. High mortality, more than 50%. So that's why propofol as an infusion, there is a maximum safe limit beyond which you cannot give. So maximum safe dose is 4 milligram per kg per hour. Maximum safe duration less than 48 hours. Not used in children for sedation. Not used in children for sedation, not for induction or maintenance. Very well we use it, but not for continuous infusion for sedation. Okay, so this is PRIS, propofol infusion syndrome, a life-threatening complication of propofol. Then with propofol, green urine has been associated on prolonged infusion due to its metabolite. Green urine has been seen, a metabolite, right? So just summarizing few things about propofol. Propofol is one of the commonest used IV anesthetic agent in today's anesthesia practice. It is IV anesthetic, preferred IV anesthetic agent of choice. So let us summarize in the end the few important points of propofol. So propofol is IV anesthetic agent of choice for number 1, daycare procedures or ambulatory surgery, daycare surgery, ambulatory surgery. Why? Because fast onset, less context sensitivity, half-life, then anti-emetic, pleasant recovery, and it is said that recovery from propofol anesthesia is such patient has not received any kind of anesthesia. So no residual drug effect. No residual drug effect. Because of all this, it is wonderful drug for ambulatory surgery or daycare surgery. Okay. Then it is a wonderful IV anesthetic agent for neurosurgery because of all good effect on your neurosurgical procedure for central nervous system. So what does it is? Cerebroprotective. It is decreasing CMRO2, decreasing cerebral blood flow, decreasing intracranial pressure. It is causing a burst suppression. It is antioxidant. Now, all this makes it a very, very good agent for neurosurgery. Then it is a wonderful agent for GI endoscopy, GI endoscopic procedures. Why? First, these procedures are daycare procedures. Second, that it is inhalational would be difficult to give in these procedures, right? And propofol, TIVA would be preferred, right? TIVA preferred for these procedures. Propofol is best in IV, anti-emetic, all makes it good for GI endoscopic procedures. Then it is good for your patient with pre-existing liver and kidney dysfunction. Pre-existing liver and kidney dysfunction. Why? It has no effect on liver and kidney, and it does not cause, its metabolism does not get delayed if there is any problem in liver and kidney because of extrahepatic, extra-renal route of metabolism through lung also. Then it can be used in patient with malignant hyperthermia. Malignant hyperthermia, it is safe in malignant hyperthermia, rather it is agent of choice. Inhalational cannot be used in malignant hyperthermia. Then it is agent of choice in porphyria. It is a wonderful agent for porphyria. Most of the IV anesthetic agent can precipitate porphyria. Propofol is agent of choice in patient with porphyria. So IV anesthetic agent of choice in porphyria. Remember this. Okay. So propofol is agent of choice in number of conditions. Some excellent properties of propofol is its anti-emetic effect, fast recovery, no residual effect, then small or low context sensitivity half-life, small or low context sensitivity half-life, then no accumulation, right? All this makes propofol a wonderful agent, right, to be used in today's clinical practice, and it's good effect on CNS, right? It's good effect on CNS, and it is safe in malignant hypothermia, in porphyria. So all this makes it a wonderful IV anesthetic agent. Okay, so this is all about propofol. The next IV anesthetic agent I will discuss would be etomidate. Now, etomidate is imidazolone derivative. It is chemically imidazolone derivative. Imidazolone derivative. You know, this is different from other IV anesthetic agent, that it is a pure enantiomer. It's a pure enantiomer which is used as a drug. Most of the other IV anesthetic agents are racemic mixture. Ketamine is a racemic mixture, right? But this is imidazolone derivative, of which D plus enantiomer is used. Enantiomer is used, right? Now, it is prepared in propylene glycol solution. Prepared in formulation of propylene glycol. Propylene glycol. This will cause veno irritation and phlebitis. So, etomidate, like propofol, can cause pain on IV injection at the site. So, nowadays, you know, even the lipid formulation is being prepared, not the propylene glycol formulation, which does not cause pain on IV injection. So, what is the additive which is added? It used to be propylene glycol, now it is prepared in lipid formulation also. Its additive is propylene glycol, and when this additive is added, it causes pain. Lipid formulation, less pain. Okay. See, propofol also, it is the propofol, the phenol, which is causing pain, not the lipid formulation, right? The MCT1, the middle chain triglyceride, they decrease the propofol in the propofol formulation, and they decrease the pain, right? So, it's propofol which is causing the pain, not the additive. Here, the propylene glycol, the additive which is causing the pain, and the lipid formulation is made which is causing less pain. So, you may find etomidate preparation from both in transparent preparation to milky white. So, both are present. So, we have transparent preparation and milky white, both available, right? Transparent preparation and milky white. You know, etomidate became very popular when it came because it did not had one major problem which most of the non-opioid IV anesthetic agent had, and that was cardiovascular instability. So, etomidate did not had that feature. It did not cause cardiovascular instability. So, it was a hit, but slowly its popularity decreased because of some unique side effects which was associated with it. So, use of etomidate is risk benefit. You have to see that what is the benefit in the clinical scenario of the patient more with etomidate, and what is the risk. So, according to the risk benefit, we can use etomidate, right? Now, let's talk about the pharmacokinetic. Like any other IV anesthetic, onset fast. Onset means vein to brain, right, is fast, and it is 30 to 60 seconds. You know, when you give IV anesthetic agent, it has a high serum concentration, and then when it achieves a high CNS concentration, the patient becomes unconscious. So, from time to blood concentration and time to CNS concentration, little bit there is a difference, and that is what is called hysteresis. And it depends upon the lipophilicity of the drug. More the lipophilic drug, more would be the more faster it would penetrate the CNS. So, less would be the hysteresis. So, what I was talking about, something called hysteresis. Hysteresis, that is difference between peak brain level and peak serum level of drug. Okay, and this is less, this would be less if the drug is more and more lipophilic. Okay, so most of the IV anesthetic agents are highly lipophilic. Then next point, so onset I told you. Okay, distribution half-life. Distribution half-life when we give the first distribution, maximum 2.7 minute. Redistribution phase, redistribution, maximum 29 minutes. And elimination half-life, the three phases, distribution, redistribution and elimination. The elimination half-life 2.9 to 5.3 hours, which is much higher than propofol if I compare it with propofol. Okay, so distribution half-life 2.7 minutes, redistribution maximum 29 minutes, and elimination 2.9 to 5.3 hours. Okay, these three important points. The metabolism of etomidate by liver. It is metabolized by liver, right? And metabolic byproduct. The metabolic byproduct is excreted through kidney 80% and bile 20%. The drug is highly protein bounded. So highly protein bounded. So in case of condition which will decrease the serum plasma protein, would alter the pharmacokinetic of the drug, right? It's a highly protein bounded drug. Remember this. Then coming on pharmacodynamic, what is the effect of etomidate on central nervous system? Mostly good effect. But before, what is the site of action, right? Site of action in CNS is agonist on GABA A receptor, and it let's say inhibitory influence on the central nervous system. So it is agonist to GABA A receptor. It is agonist to GABA A receptor and thus inhibitory influence on CNS. Okay. Effect on central nervous system, other effect. This is the site of action. Other effect. So till now we discussed the second drug, propofol first. It was also GABA facilitatory effect it had. Main effect was GABA facilitatory. Etomidate also GABA agonist. Now let us talk about other effect on CNS. Like it's also like propofol a cerebral vasoconstrictor. It decreases cerebral metabolic oxygen requirement. So decreases cerebral blood flow. So decreases intracranial pressure. And since in next pharmacodynamic effect on cardiovascular system, I would write it is cardiovascular stable. Since it is cardiovascular stable, it will not decrease the blood pressure. It will not affect the mean arterial pressure, right? Rather I should write mean arterial pressure. So mean arterial pressure would not be affected. So what will happen? The cerebral perfusion pressure would be increased or maintained. So it will maintain cerebral perfusion pressure. This is a better effect, perfusion pressure, than as compared to other anesthetic agent. Propofol was also decreasing intracranial pressure, but it was also decreasing mean arterial pressure. So cerebral perfusion pressure, we all know, is the difference between mean arterial pressure minus intracranial pressure. So though this was decreasing, this was also decreasing. So cerebral perfusion pressure was let's say little bit decreasing. But since it is maintaining the mean arterial pressure, it is rather maintaining or increasing the cerebral perfusion pressure. A good thing, right? Then one important thing which we need to know about etomidate is that it has shown burst suppression like propofol, burst suppression. So it is also neuroprotective like propofol, neuroprotective. But in EEG, some EEG changes has shown epilepto epileptogenic effects, right? It decreases the threshold of epilepsy, threshold of seizure. This decreases threshold of seizure, right? So that is why not preferred for neurosurgery. So not preferred for neurosurgery. But for electroconvulsive therapy, where we need seizure, where we need seizure to see whether the electroconvulsive therapy is adequate or not, this can be a good agent. Etomidate can be good induction agent, right? So for ECT, it can be good agent, electroconvulsive therapy, but not for neurosurgical cases. Since it is epileptogenic, we would not prefer it. Okay. Then cardiovascular system, the star point of etomidate, I'm making a big star point of etomidate, is its cardiovascular stability. Etomidate is the only non-opioid IV anesthetic agent which is cardiovascular stable. What does it do? It does not do anything on cardiovascular system. So that's why it is cardiovascular stable. No effect on mean arterial pressure, no effect on mean arterial pressure, no effect on pulmonary arterial pressure, no effect on pulmonary artery wedge pressure, no effect on CVP, stroke volume, cardiac index, your systemic vascular resistance, your pulmonary vascular resistance, no effect. That's why I would go on writing no for cardiovascular thing. So that is why in near cardiovascular surgery operating room, this is one drug which is used, right? So good to use for cardiovascular surgery, because it keeps the hemodynamic stable, okay? Now it can also be used in shock patient, but the problem is, I will discuss a side effect in which I will say it causes inhibition of cortisol synthesis. So this is a major problem of etomidate. This is a black star point, and because of this, in shock patient also we need cortisol to maintain the hemodynamics. I mean, it becomes inferior to ketamine, right? But otherwise, for cardiovascular surgery and for shock patient, we can use etomidate because it keeps the hemodynamic stable. Okay. Now respiratory system. Now, like any other IV anesthetic agent, depress respiratory center. Like any other IV anesthetic agent, blunts hypoxic and hypercapnic drive. Like any other IV anesthetic agent, bronchodilator, right? All this. Just remember that depuration of respiratory center and blunting of hypoxic hypercapnic drive is less compared to propofol, right? Less compared to propofol, okay? Hepatic and renal, no effect. Hepatic and renal, no effect, okay? Keep it in mind. Now let us talk about uses. We use it for induction in patients with cardiovascular compromise, okay? Dose is 0.2 to 0.3 milligram per kg body weight. Okay, dose is 0.2 to 0.3 milligram per kg body weight, right? So basically it is used for induction in cardiovascular compromised patient, can be used in shock patient also, as I already told, but ketamine would be preferred. Ketamine would be preferred, okay, than etomidate, because it causes adrenal suppression. Now coming on the side effects. One side effect already told you, because of propylene glycol, it causes pain on IV injection. This was the first thing which we discussed. in the etomidate that it has propylene glycol present, prepared in propylene glycol, and this propylene glycol causes veno irritation, and because of this veno irritation there would be pain. The incidence is 30 to 40%, less than propofol. The milky white preparation, that is the lipid emulsion of etomidate, is causing less pain. Now myoclonus has been seen, right? Myoclonus has been associated, incidence very high, 60 to 70%. Incidence of myoclonus is 60 to 70%. Okay. Now one major side effect, adrenal suppression. Single dose, single induction dose, temporarily suppress adrenal gland for 48 hours to 7 days. This is temporarily doing 48 hours to 7 days. Suppress the adrenal gland. Actually, adrenal cortex, right? And there is an enzyme in adrenal cortex which is inhibited, 11-beta hydroxylase. Now, this is an essential enzyme which would lead to change, transformation from cortisol to cortisol, right? So, final cortisol formation requires this 11-beta hydroxylase. So, 11-beta hydroxylase inhibited. So, what happens? Cortisol synthesis inhibited. So, they say that if you give etomidate with dexamethasone in the background, then this can be minimized, right? But it is a temporary thing. It does not irreversibly causes adrenal suppression. But since cortisol is a vital hormone required for maintaining hemodynamics and all, so this side effect we have to keep in mind. Then PONV. This is one drug in which I write PONV in side effect separately. For rest, inhalation, anesthetic agent, I told you, they all cause PONV. Propofol is antiemetic. Etomidate is highly emetogenic. That is postoperative nausea and vomiting, right? Highly emetogenic, one of the most emetogenic drug, okay? And then thrombophlebitis because of veno irritation. It can cause thrombophlebitis, because of veno irritation. Okay, so this is the side effects which we have to remember. Myoclonus, thrombophlebitis, highly emetogenic, and pain on injection. And one major side effect, adrenal suppression. All these side effects has little bit to some extent decreased its popularity as IV anesthetic agent, right? For induction, adrenal suppression for 48 hours to 7 days. If you use it for maintenance, this can get prolonged. So that is why it is mostly used for induction. For maintenance, it is not preferred, even in patient with cardiovascular compromised. So even in patient with cardiovascular compromise, we use it mostly for induction. During induction only, hemodynamic imbalance is more of our concern. For maintenance, at multiple, let's say balanced anesthesia, at multiple agents which we are using, we can maintain the hemodynamics more compared to as we can do during induction. Got it? So this is all about our etomidate. Okay.